1995, Mankind Pharma has become a leading pharmaceutical company in India. Founded by Mr. R.C. Juneja, Mankind is run under the leadership of a highly experienced management team. Mankind Pharma is number one as per prescription audit and has strong presence across prescription drugs, OTC, and veterinary medicines. Our philosophy is serving life, and towards that, our three basic principles is quality medicines, affordability, and availability. Over the years, we have well represented ourselves in almost all major therapeutic areas with leadership. Mankind Pharma has its own research and development capabilities where we aim at developing novel and differentiating scientific solutions through innovative products. And we thank you for your continuous support and encouragement for us. Now, with this, I hand over this session to Dr. Prashant for further proceedings. Sir,
thank you, Shiva. Thank you, Shiva, and welcome everyone once again. This is a radiology workshop which we have been conducting from last many months and seeing the tremendous response which you have shown to us. So this is something, it is really important to us to understand what actually chest X-ray, CT scan, the radiology all together actually, and how can we correlate with the clinical findings. So for that, here once again we have Dr. Raju Rastogi sir, who is professor at Department of Radiodiagnosis at Ketanka Mahavir Medical College. Graduate in radiodiagnosis and also done postgraduate diploma in musculoskeletal ultrasonography from Spain. He is a fellow of International Medical Science Academy and Indian Radiology and Imaging, besides being a member of multiple prestigious academic, including National Academy of Medical Sciences, Radiological Society of North America, European Society of Radiology, and Korean Society of Radiology. He has been guest speaker in multiple CMEs and national as well as international conferences, including Royal College of Physicians and Surgeons, Glasgow, Gastroenterology Conference in Rome, Indian Radiological and Imaging Association 2020, and has chaired scientific sessions in such gatherings, including Resident Training Program, IRAP 2019 and Ultravision 2019 in New Delhi. He has more than 160 international papers and more than 50 chapters in various textbooks related to radio diagnosis. So with this, I invite Dr. Professor Raju Rastogi sir to take the session further. Sir, over to you. Dr. Raju, you are on mute.
So now I am audible?
Yes, yes.
Okay. So today we will be discussing about the complications that we see once the person has suffered from COVID. So it may be early complications or it may be delayed complications. And the next part of our today's webinar will be on the radiological findings in various allergic conditions, specifically those involving the lung and also the sinuses. So let us first recapitulate that whenever a suspected patient of COVID-19 gets a HRCT thorax scan.
Sir, if you are showing any PPT, so you have to share. Sir, it's not yet shared.
Okay. So I think I had shared the PPT. Share screen. Okay. So now it is visible?
Yes, yes, it is coming now.
Okay. So now, just to recapitulate that whenever a suspected patient of COVID-19 gets a HRCT thorax, we have been categorizing the pulmonary parenchymal findings into 6 categories from 0 to 6, where 0 is not interpretable in terms of the quality, whereas 1, 2 were having a very low and low suspicion of COVID-19, category 3 or CORADS 3 is equivocal, so equal possibility of COVID-19 as well as any other disease with similar appearance, and category 4 and 5 with high and very high suspicion, whereas CORADS 6 was given only when the patient comes for HRCT thorax after getting a RT-PCR test positive. So what were the typical findings? We need to know this because all this will lead to complications accordingly. So the classical findings that have been described in any viral pneumonia per se is ground glass opacities with or without consolidations. And when it comes to COVID-19, it has to be adjacent to the visceral pleural surfaces, including the fissures. However, the true subpleural sparing can be there. And it is always multifocal and bilateral. So it will involve all the lobes, all the zones bilaterally. It may be asymmetric or symmetric, that doesn't matter. And these ground glass regions can be unsharp or may have a round appearance, or they may be very sharp, just like consolidation, but they will allow the vessels to be seen through them. And they may even be as small as outlining the secondary pulmonary lobules just adjacent to the pleural surface. Then there will be a crazy paving pattern, which is often described as irregular areas or geographical pattern of the ground glass haziness. Areas may correspond to the organizing pneumonia as the disease progresses. And there can be thickening of or the vascular dilatation within the areas of the ground glass haziness. And this has been described as a classical sign, which is seen in around 15 to 20% of these COVID patients. Then there was a CT severity scoring system, which actually was based on the percentage of the lobar involvement in both the lungs. So the summation of all the scores in all the lobes will give rise to the final score out of 25. So with this background, now we come to the pulmonary complications. So post-COVID pulmonary complications can be broadly categorized into primary and secondary. Primary are the ones which are directly related to the pulmonary findings secondary to COVID-19 pneumonia. So this may be fibrosis, diffuse pulmonary fibrosis, or maybe peripheral. Then there can be pulmonary thromboembolism. We all know it can occur during the phase of COVID pneumonia, that is acute, or maybe when the patient becomes COVID-19 negative. So this may occur during and after the COVID-19 pneumonia. Then there are secondary complications which are related to the immunocompromised state secondary to COVID-19 pneumonia. So these can be fungal diseases, pneumothorax, Cox chest, and we will see as the webinar progresses. So now this is a digital chest radiograph in AP projection of a patient showing that there are diffuse reticular opacities involving nearly symmetric both the lungs in all the zones, and the overall volume of the lung is low. There is no definite fibrotic bands except for this large band. The entire lung is involved, and we see a typical reticular pattern. When the chest CT was done, we see that there is asymmetric involvement. The involvement is more on the right side, and we see the areas of fibrosis. We see traction, bronchial dilatation, and this was involving both the peripheral subpleural location. For example, in this area, we can see that there is interlobular septal thickening giving rise to the secondary lobule or marginating the secondary lobule, and there are irregular haphazard areas which give rise to the crazy paving pattern. On the other side, we do not see a major involvement. However, similar findings are seen, and this is a radiolucent area which may correspond to the normal lung in this patient. This is the coronal MPR image of the same patient, which again shows that the right lung is more involved. The bases are more involved than the apical regions, which is again classical for the COVID-19 pneumonia. However, in this case, the left lower lobe was relatively uninvolved. However, whenever there is a diffuse pulmonary disease of significant duration, there is a complication which is known as the pulmonary arterial hypertension. So when this patient got a CCT thorax done, so this is a mediastinal window setting where we see the ascending aorta and we see the main pulmonary trunk dividing into the right pulmonary artery and the left lobar artery. So here what we can see, the main pulmonary trunk and the right pulmonary artery is dilated. Normally, the ascending aorta is usually larger than the main pulmonary trunk diameter. In this case, visibly we can see that this main pulmonary trunk is larger than the ascending aorta. So this is dilatation secondary to the increased arterial resistance which is being offered at the pulmonary bed in the right lung. However, we noted that the left lower lobe was relatively normal, so the left lung was less involved. That is why we are seeing a normal left pulmonary artery. So, whenever we are evaluating the patients for the diffuse pulmonary fibrosis or the post-COVID complication, always remember that you need to look at the pulmonary artery to rule out the pulmonary arterial hypertension, because this is a noted complication. We talked about the pulmonary thromboembolism as the primary complication. So this can be secondary to the pulmonary arterial thrombus, or it can be an embolus from the deep veins of the leg. So that is why it is from a venous thrombosis and they lodge into the pulmonary arteries through the right side of the heart. The basic involvement is of the segmental and the lobar artery. So in this case, we can see that the arteries are filled with contrast. At the same time, there are some eccentric filling defects. So whenever we see filling defects within the angiograms, we say that it is the thrombus. It can be eccentric or it can be completely occupying the lumen, not allowing the contrast to pass through it. So the distant vessel will not be seen. Whenever this happens, we will get the arterial infarcts, and infarcts we all know are wedge-shaped areas in the same distribution. So in this patient, in this lung window, we can see that there are wedge-shaped areas which are located in the subpleural location. So these are the thrombus in the pulmonary arteries. We can see in this image also, this is traveling across the artery and very little contrast is seen outlining the clot, and we are seeing the subpleural small wedge-shaped pulmonary infarcts. Also noted is a reverse halo sign in this case, where there is a radiolucent area or the hypodense area surrounded by a thick rim of high density or high attenuation. So this is a reverse halo sign. So this was in a patient old patient who was proven to be COVID-19, but this thromboembolism occurred nearly 16 days after, when the patient has already become COVID-19 negative. So the pulmonary thromboembolism can occur during and after the post-COVID pneumonia. So this brings us to the quiz 1. So this is the chest X-ray, which is taken in the AP projection. So what is the finding on this chest X-ray? And look at the distribution of this disease on this HRCT scan. So please note down your findings and please send it into the chat box of the YouTube. So you have 15 seconds to register your response, and then we'll see the answer to this quiz. So what is the disease and what is the pattern of the disease? So the disease is quite evident on the chest X-ray, but the pattern is well visible on the HRCT. So I think majority of you has given your response. So coming to the answer to this quiz. So this is, as we have noted in the previous slides, this is post-COVID fibrosis. This X-ray is similar to the one we have already seen. So there is a reticular pattern, but this reticular pattern has got something different what we have seen. Here it is mainly peripheral. So it is going up along the lateral chest wall on the chest X-ray on both the sides, and this is well confirmed on the HRCT scan. So we are seeing that this is mainly peripheral, less of the central, and that is why this patient is having this type of appearance on the chest radiograph. So there can be a diffuse pulmonary fibrosis post-COVID, or there can be a peripheral pulmonary fibrosis which can involve all the lobes in both the lungs. So now coming on to the post-COVID fungal disease. So how do we diagnose this? How does it appear? We have been seeing a lot of cases of the fungal disease, and we have been treating them. So how one should suspect that there is a fungal disease? So this patient is a middle year male patient who presented with cough, dyspnea, and fever of around 100 to 101 degree Fahrenheit, and the sputum, this was a productive cough. So this was the chest X-ray taken on the 24th of September in this patient. This patient also had diabetes, which was uncontrolled at the time of the presentation. So the patient was treated with antibiotics, the blood glucose control was managed, and the X-ray was again repeated on the 2nd of October. But in spite of so good antibiotics, there was no significant change, although some opacities appear to become relatively less dense. Then another X-ray was done around 10 days after with the same treatment. And now what we can realize that there is no significant change in almost 3 weeks of the treatment. By the last X-ray, the patient's glucose control was well maintained, but the fever, cough, dyspnea was still persisting, although it was 10-20% less than what was at the time of presentation. So this made us to believe that there was some disease which is not responding to our routine antibiotics. This patient lung background forced us to think about the COVID as a precursor of this disease. The history was taken, and ultimately the patient gave the history of the COVID pneumonia in the month of June. So now we can correlate that there was a non-resolving type of pneumonia which was not responding to the antibiotics. And since the patient was immunocompromised because of uncontrolled diabetes, this patient probably developed a fungal disease. And now if we look back, we can see that there is cavitation and there is fluffy cotton wool-like appearance. Again, here also there is some cotton wool-like appearance. And this is a dense shadow, ball-like shadow, which in the third X-ray looks, because of its penetration of the X-ray, we can see some cotton wool-like appearance within this. So probably all these were fungal abscesses. And when the HRCT thorax was done after the 2 to 3 weeks of the antifungal treatment, so we saw that these lesions had become smaller in size. So now we know that if there is a non-resolving pneumonia, there is immunocompromised state, history of COVID, then we should think of the fungal disease, because they will not respond to the routine antibiotics, and before it leads to further complications, we have to treat it as early as possible. So in this case, we see the sequelae of the COVID pneumonia in the form of fibrosis, which is bilaterally asymmetrical, but it is in the subpleural space, and there are small fungal abscesses which are healing in nature. Now, we have talked of a fungal abscess, but there is something which is also known as fungal pneumonia. The abscesses appear after the pneumonias, and at times they appear when the patient is severely debilitated. Then the patient develops the abscess without radiological appearance of the pneumonia. So in this patient, again, there was a non-resolving areas of consolidation in both the lungs, which was asymmetric. Here it is the right lower lobe, and here it is the left upper lobe. When the chest CT was done, this is a mediastinal window, which is in between the true mediastinal and the lung window. We see a different type of consolidation. We do not see too much air bronchogram, although it looks like consolidation, but we can also see certain vascular markings through it. So it is a combination of roundless appearance with an organizing pneumonia. It's not a true consolidation that we see with bacterial pneumonia. So it was a atypical consolidation. So when the lung window was seen, so we could see that this is a large area of loss of pneumatization, but still it is a combination of the two. It is thick at the periphery and relatively less dense in the center. So this is classical of the fungal pneumonias. And also we could see that there is a ground glass area in the adjacent segment. So this is a case of a large fungal pneumonia. And when we see on the virtual lung windows, we see that this area is actually, there is no destruction of the lung parenchyma, but it is the consolidation. As the disease will progress without treatment, so ultimately there will be more and more cavitation and it will give rise to a true fungal abscess. So another case which was complicated by a pyoneumothorax in a pre-existing fungal disease in a post-COVID patient. So here what we can see, there is a thick rind of the fungal abscess. There is internal septations which corresponds to the hyphae, and there is some pneumothorax lying in the left pleural space. There is some pleural fluid as well. Lower down, we see that there are multiple fungal abscesses appearing in the right lower lobe, larger in the left lower lobe, and there is again a large pneumothorax in this patient. The mediastinal window in this patient shows a large air fluid level in the basal part of the right of the left pleural space. So this is an axial image. This is a sagittal image through the left hemithorax, and where we can see again the air fluid level. So we are seeing a vertical air fluid level because it's a reconstructed image from the axial image. So that is why we are seeing a vertical air fluid level. So there was an existing fungal abscess which was further complicated by a bacterial disease leading to the pyoneumothorax. So that is why we know that not only the fungal disease can occur in the post-COVID lungs, but it can be further complicated by the bacterial disease. So it is very imperative for all of us to identify the fungal disease as early as possible so that it can be prevented from further complications. So this brings us to the quiz 2. So identify the complication in this post-COVID patient and note down your response in the chat box of the YouTube. You have 15 seconds to do so, and then we'll discuss the answer to this quiz. So remember that this is a post-COVID patient. We can see the fibrosis, we can see the peripheral distribution, we can see interlobular septal thickening. Both the lungs are involved, but in the left lung, you have one additional disease, and in the mediastinal window, you can also note one additional complication. So I think majority of you have noted down your response. So this is a case of a fungal abscess in the post-COVID patient along with empyema. So there is a pleural collection, and why we say it's empyema, because we can see the parietal as well as the visceral pleura thickened and enhancing. So whenever we see both the pleural surfaces enhancing with collection, it is empyema. Ultimately, it leads to the fibrothorax, and there is a fungal disease also. So this is a case of a post-COVID fungal abscess with a pyothorax. So there are two complications of the COVID pneumonia. So now, because there is a lot of fibrosis, so the patients might have other complications secondary to the pulling and the tagging of the pleural surfaces. We all know that scarring is always irregular. It destroys the architecture of the normal lung, and the gaseous exchange becomes
Sir, your voice is not.
Okay, now I am audible?
Yes, yes.
Okay. So there was some power breach. So this is a case, we all know that the fibrosis and scarring destroys the parenchymal architecture, and this actually disrupts the gas exchange, and this is the reason that the patient suffers from the dyspnea. And these patients, because of the tagging, because of the pulling, scarring, they develop the bronchiectatic cavities also. And these bronchiectatic cavities ultimately become the source of the secondary infection by the bacteria because of the pool secretions. And these patients will continue to have a productive cough and off and on acute episodes. Now, sometimes these consolidations, these pneumonias can lead to the pseudoaneurysm formation. And what is a pseudoaneurysm? When the vessel wall is weakened because of some infection, so it gets dilated and it gives rise to the aneurysm. And this is known as a pseudoaneurysm. So this is a post-COVID patient showing fibrosis in the lung, and there was a area of consolidation. This patient actually presented with hemopsis as well. So when the chest X-ray was done, it was not very significant. There was some area of haziness and a patchy opacity. So when the CT was done, it was done in a dual phase, an arterial and a venous phase. So in the arterial phase, we could see some enhancement, a rounded enhancement similar to the adjacent descending thoracic aorta within that area of necrosis in the consolidation. So this corresponded to the pseudoaneurysm. So these are the multiplanar images in maximum intensity projection in the area of consolidation, and we can see that this pseudoaneurysm is arising from one of the pulmonary arteries. So pseudoaneurysms can arise from the bronchial arteries and they can also arise from the pulmonary arterial branch. So this was a case of a pseudoaneurysm in the post-COVID consolidation, and this was the cause of the hemopsis in this patient. So this has to be this pseudoaneurysm has to be treated before this patient will actually be relieved of the hemopsis. Now, initially we thought that the patients with tubercular chest are not that prone to develop the COVID pneumonias, but now what we are seeing is those patients who have had an episode of COVID-19 pneumonia, they are frequently developing Cox chest, probably because of the immunocompromised state that have arisen secondary to COVID-19 pneumonia. So this was a patient where there is a lot of fibrosis in the bilateral lower lobes, and the left lower lobe was more severely involved. But in this patient, we could see classical necrotic nodal masses as well as discrete nodes. This is a large coalescent node. There is a right hilar node. There is a left hilar node. So this patient, who was a COVID-19 pneumonia patient, so he developed Cox chest around 2 to 3 months following his recovery. So we have to keep in mind, because the COVID-19 pneumonia can actually reduce the body immunity to fight with other infections. So there can be a recrudescence of the silent infection that is already there within majority of us. So not only the complication can occur within the lung, but often it can be there in the adjacent abdominal organs. So we should remember that whenever the patient comes to us with cough, fever and dyspnea, we have to look at the lungs, but never forget to look at the organs which are seen in the upper abdominal region with the HRCT thorax. So in this patient who was showing typical pulmonary fibrosis involving both the lungs, the left lung was more severely involved. So the cause of fever was not the pneumonia or the fibrosis. The cause of the fever was this collection which was lying within the spleen itself. So this patient, post-COVID patient developed a splenic abscess, and the patient was also having a diffuse lung fibrosis secondary to COVID-19 pneumonia. Now, this brings us to the second part of our today's webinar, which is concerned with the common allergic conditions. So, the allergies usually present with cough, dyspnea, which are not responding to the treatment, and at times the cough is productive in nature. So, the allergy can lead to diseases, or the diseases can manifest in different forms. So, such patients, when evaluated, may have different patterns. For example, they can have bronchiectasis. So in this patient, what we see are variegated dilatation of the bronchi in these two images. So we are seeing cystic dilatation. We can see cystic dilatation here. We can see the secular dilatation, and at times we also see varicoid, which does not correspond to any shape and size. And this is asymmetric. It is involving all the lobes. It is more severely involving the right lung. And at the same time, what we see is the thickening of the bronchial walls. So this is not only a patient with bronchiectasis, there is an element of bronchitis also. Normally, we say that only the medial 2/3 of the lung field contains the bronchus. The lateral 1/3 usually contains the bronchioles. So whenever we see such dilatation reaching almost up to the pleural surface, so as in this case, at this location and also here, so we should think of bronchiolitis as well, bronchiectasis and bronchiolitis. So this is a patient which will commonly have cough, dyspnea, and off and on acute fever also, with change in season also, because this patient has got a bronchiectasis with bronchitis, bronchiolitis, and bronchiectasis. So these things can be picked up very well on HRCT scan. Although on digital X-rays, full-blown bronchiectasis can usually be picked up, but early bronchiectasis requires HRCT thorax. So one common condition that we see is allergic bronchopulmonary aspergillosis, where there is a immune-mediated inflammatory response. So if we see the X-ray of this patient, it shows us ill-defined shadows. We are unable to characterize. At some places there are linear shadows, at some places there are rounded shadows. So it's difficult to put this pattern as far as the chest radiograph is concerned. And many of us might believe that this is tubercular. But when the HRCT thorax was done, we could see the dilatation of the bronchi, which are located close to the hilum. So there is a different pattern of dilatation, and some of the dilatation was completely filled with some soft tissue or fluid, thick fluid-like material, and this is a typical U-shaped, V-shaped branching pattern, which is known as a gloved finger appearance, and this is classical for bronchoceal formations. So this was a case of allergic bronchopulmonary aspergillosis because of continuous long duration productive cough. This sputum gets inspissated within these dilated bronchi, and it is commonly the central bronchi which are more commonly affected. We all know that the dyspnea can be because of the emphysema also, which occurs more commonly with the smokers, and the chest radiograph will show us the hyperinflated lungs, flattening of the domes of the diaphragm. There will be increased radiolucency of the lung, and there will be redistribution of the blood. So the pulmonary vasculature in the lower lobes will either become equivalent to that of the upper lobes, or maybe vice versa as well. And the HRCT thorax in such cases can show us the typical pattern of emphysema. For example, in this case, it is paraseptal emphysema, which is located in the subpleural space in the bilateral apical regions. The destructive emphysema can also be a part of the spectrum in the diffuse disease, which is seen in the smokers. And here what we see that there is a centrally acinar type of emphysema, panlobular emphysema, but there is complete loss of architecture in this area, and that is known as a destructive form of the emphysema. And again, it is very common in chronic smokers. The coronal MPR images will depict these findings. So in this case, bilateral upper lobes are involved, and there is some element of the paraseptal emphysema also. So there are now automated softwares available with some of the vendors and the high-end machines, where we can actually objectively grade, or rather quantify the areas of the lung destruction, and this can help us in determining the prognosis in these patients. So now, one of the common cause of the dyspnea is bronchial asthma, and in emphysema also we have got the similar type of dyspnea. So besides a lot of clinical differences, if we look at the chest X-ray, we see that both have the hyperinflated lungs. The radiolucency will be relatively increased on both the sides, but it will be more increased in cases of emphysema. And in emphysema, what we really see is redistribution of blood. There is pruning of vascular markings, whereas it is not there with the asthma. So here what we see, bilateral hyperinflated lungs, flattening of the domes of diaphragm, but still the vasculature in the bilateral lower lobes is still visible. But on the other hand, if we look at this emphysematous patient's X-ray, so we see that there is pruning of the vascular markings, specifically in the lateral half of the lung field, and in the bilateral upper lobes, we don't see any vascular marking. But if it is the initial stage of the emphysema or a well-blown asthma, we would require HRCT thorax if the clinical distinction is not evident. One important cause of the dyspnea and the various forms of lung allergies is the hypersensitivity pneumonitis. As far as HRCT is concerned, this condition cannot be diagnosed with chest X-rays. The typical history is very important, and on HRCT, a typical pattern of central acinar nodules. So if you see a secondary lobule and a tiny nodule in the center, which are usually very discrete in nature. So this is a case of acute hypersensitivity pneumonitis, and in such cases, we have to go back to the patient's history and find out the exposure to any allergen which is there. And this is a patient with subacute to chronic hypersensitivity pneumonitis, where there is diffuse haziness in both the lungs. There is some interstitial septal thickening, and this poor quality is because of the dyspnea of the patient, which does not allow the patient to hold the breath for sufficient time required for optimal CT scanning. So this hypersensitivity pneumonitis starts with central acinar nodules, goes to the ground glass haziness, thickening of the interlobular septa, and ultimately there will be fibrosis, as in this case we are seeing in the lower lobes, and ultimately there will be loss of volume of the lungs. And in the late stage, it is very difficult to distinguish this chronic hypersensitivity pneumonitis from the UIP pattern of the ILD. So it is only the early stage and the subacute stage where we can make this distinction. In the UIP pattern, usually we will have the involvement of the subpleural interstitial septae, and the disease starts from periphery towards the central part. Whereas in the hypersensitivity pneumonitis, the fibrosis usually is more central, and it then slowly progresses towards the periphery. We all know that a lot of patients come off allergy, come with severe sneezing. So nothing much in radiology, but whenever a X-ray PNS or HRCT PNS is done, it is basically to rule out other organic diseases. But we will definitely see some mucosal hypertrophy of the bilateral inferior and the middle turbinates in this coronal CT PNS. And in this case, we can see the inferior turbinate hypertrophy. We are unable to see the lucency of the nasal cavities. So this is what we can see on a chest X-ray PNS and the coronal CT in a patient with allergic rhinitis. Then some patients may show polypoidal structure, a mucosal polyp lying within the antrum, which can be the cause as well as a sequelae of chronic rhinitis. Here again we see the inferior turbinate hypertrophy, mucosal hypertrophy seen. So this can be an antral polyp or a retention cyst. The only difference radiologically is the in the size. So if it is less than 1 centimeter in diameter, it is more likely to be retention cyst. And if it is more than 1 centimeter in diameter, we call it a antral polyp. Otherwise, we cannot differentiate between the two. But what is important is there is no destruction of the walls. There is no remodeling. So this tells us that this is a benign disease and it's not anything infectious in nature. So this brings us to the quiz 3. So these are the HRCT thoracic scans which show the opacities. So what is the disease entity in which we see this type of the pattern on HRCT thorax? And please note your response on the chat box of the YouTube link. And then we'll discuss what is the disease. We have seen this in the previous slides. So just a recapitulation of what you have seen. So I think majority must have noted your response. So coming on to the answer, so it is allergic bronchopulmonary aspergillosis. So in this case, we are not seeing any dilated bronchus filled with air, but what we are seeing is the branching pattern of the bronchus. So these are bronchoseals. So typical branching pattern, V and Y-shaped opacities, structures which correspond to the finger and glove appearance, and peripherally there is peribronchial fibrosis or bronchiolitis because we are unable to resolve this area, so they appear as two very small dots or opacities which are again branching. So again, this was a proven case of allergic bronchopulmonary aspergillosis with bronchosele formation, and there was some subsegmental atelectasis of the superior segment of left lingular lobe. So coming on to the end of this webinar, the take-home message is post-COVID complications are frequent in immunocompromised state, specifically the uncontrolled diabetes mellitus. It is the high index of suspicion which is required for early diagnosis. High resolution CT thorax coupled with CT thorax is the standard staging imaging modality. HRCT thorax is also useful in diagnosing bronchiectasis and its complications like bronchosele formation, at times differentiating between asthma from emphysema, diagnosing hypersensitivity pneumonitis, and very importantly in allergic bronchopulmonary aspergillosis. HRCT PNS is useful in evaluating the paranasal sinuses and nasal cavities in suspected allergic conditions related to the nasal cavity and paranasal sinuses, mainly to rule out the other organic disease. Thank you very much for patient listening. Over to you, Dr. Prashant.
Thank you, sir. Thank you so much for this another wonderful session. Now I will declare for the thank you note, Ms. Shiva from marketing team of Mankind. Shiva?
Yes, sir. So on behalf of organizing team of Monticope Radiology workshop, it's my privilege to propose a vote of thanks. So thank you everyone for sparing your valuable time, and also special thanks to Dr. Rajul Rastogi for enlightening commendable talk on the subject. And thank you, Dr. Prashant, for moderating the session. Thank you so much, everyone.
Thank you.
Thank you.